Hi, everybody. I am so excited about today's webinar guest. This is my dear friend and fellow certified professional compliance officer. And I'm going to say that a lot because we worked real hard to add those 4 letters behind our name. But this is Miss Wendy Lee. She is a senior coach for Breakthrough Coaching. She is an absolute genius when it comes to managing an office efficiently. We were just joking before we got started about how every time I'm like, you know what would be a really good idea? And she's always like, I got a form for that. This is no joke. Anything you could possibly dream of, she's already thought of it. And she's absolutely amazing. Smartest decision Dr. Sean Lee ever made was marrying Miss Wendy Lee right here. Now, for the past 15 years-ish, she's also been co-owner and office manager of her husband's office in Maryland. And she is the mother of 3 of the most beautiful dancers you have ever seen. Like, seriously, talented, graceful, beautiful, and they're absolutely hilarious. So, beside the point, but they get all of their talent, good looks, and humor from this lady right here. So, without further ado, thank you, Wendy, for being here today.
Well, thank you. I think I need you to follow me around all day and introduce me to everybody all the time.
Oh, I wish.
That would be awesome. So let me bring up my presentation. Let's see if I can be technically advanced here. Apparently, I can't. Hold on.
Oh, you're doing a good job.
Oh, there we go. Can you see it?
I can.
Okay, good, because all I see is my slides now. Okay, so we're going to talk about reduce and prevent insurance claim denials. Now, what's more boring than insurance or denials? Nothing, but it is really, really important to the bottom line of the office. And I don't know about all of you, but you know, we got down to 30% capacity during COVID. So right now, every dollar counts, and these denials are even more important than ever. So we're going to talk about how this is a team approach. She kind of went over who I am already. We are in practice. So anything I talk about today is currently what I'm seeing in our practice. It's how I manage our practice. If I talk to you about a system, we actually do this in our office. So we're really going to talk about what are the wealth of reasons for not paying claims? Those insurance carriers, every claim they deny and you don't do anything about, they win the game. I talk with my clients all the time. They're like, well, insurance, should I take insurance or not? And it really has to do with, are you willing to play their game? Because they hold all the cards and make all the rules. So if they deny and you let them keep it denied, then they have won. So what we're going to cover is how to address these insurance denials, organize and follow up on your appeals, and really how to prevent denials, because I don't even like to see them come across in our office. We want to keep them to a minimum with good management techniques and the most common reasons for rejections and what you can do to deal with them. So I always like to ask everybody when I'm in seminars, I always have people raise their hand, whose job is it to prevent or manage denials? And I always ask open-ended questions, and you all can't talk back, which is super sad, but they usually say it's the biller, or they usually say it's the insurance person, but really it's everyone in the office. Front desk is important to prevent denials, insurance person, whoever does the insurance talks or puts the insurance into the EHR system, whoever the actual biller person is, the doctor is super important, the manager of the office is important, and of course the owner needs to know what's going on. So you start at the beginning and it goes all the way through the loop of the entire office. Nobody is more important than others in this whole entire process. And I like to think of it as like playing dominoes. What you do or not do affects more than just today. So it's a domino effect. So if I'm at the front desk and I put somebody's date of birth wrong into the EHR software, it's going to create a domino effect of it might get stuck in the software, it might get rejected. Once it's rejected, if we're not managing that, then those claims never got on file, they'll never get paid. And all I did at front desk was just not put the birth date in correctly. It seems so small, but it really does have lasting effects all the way through. So it's not just the biller's responsibility. So if I told you all that you were going to work really hard for the rest of today, all day long, I want everybody on their game, tip-top shape, and then it comes to the end of the day, I'm not going to pay you for any of those hours, None of you would be on board with that. But when we let denials go through, that's what we're doing to our doctors. They work hard to treat these patients, and then they're not getting paid for these visits. And so when you think of it like that, it makes sense of why it is so important to get paid for these visits. Plus, getting paid for these visits is what keeps the lights on in the office. I always believe that the easiest way to fight a denial is prevention. It's the key. When you can prevent a denial, you're stopping that domino game in its tracks so that that error doesn't go any farther. Preventing denials, having with knowledgeable staff. So the more knowledge all the staff members have, the better you're going to be as a team. So training will help you have knowledgeable staff. Systems, organization, checks and balances. And checks and balances is key. So oftentimes you'll have a fabulous department in the office and you trust your staff, but there's no oversight. So you don't really know what's happening as a business owner. And that's when things can go awry a little bit. You don't know what's going on. So I don't do any of the billing in our office, but I know exactly what's going on because I have little ways to touch in and to check and see what's going on. And why is checks and balances so important? Well, I have 3 daughters. 2 of them are straight A kids, but neither one of them get 100s on any test that they take. They're still an A kid. They're still pretty smart, but it's really hard to be 100% of the time. So that's what checks and balances does, is it looks for those errors and it makes sure that as a practice, you're at 100%, not necessarily each individual person, because that's just not obtainable. Having everybody have knowledge is key. So if you only have one person who is your insurance person and they go out sick or they go out and have a baby or you lose them for some reason, then you have a hole in the office. So I really like all of my staff to be cross-trained. Nobody likes insurance verifications in my office, so everybody has to do them, and we share the sadness in doing them, but they're important. The more knowledge you have, the more confident you can be. And it's super, super empowering as a front desk person or as an insurance person or doing appeals. If you know what you're doing, you can argue that point to the T. So who needs to be knowledgeable? The doctors, the front desk, the insurance staff, the billing staff. Everyone needs to be super trained in the office. Now, she joked that I'm like the queen of systems. I love systems. My background is in math. I actually have a math degree. And I like when 2 + 2 = 4 all the time. So in my office, systems are good because if you look at this picture, it's the clearest way to get from point A to point B. If there's no clear systems in place, who knows how or when, if you'll ever get to point B. And if you do, are you going to be denied for timely filing? Nothing makes me madder than getting a timely filing denial, because that's one of the easiest ones to prevent. So systems provide clear direction, a clear list of tasks. It's clear expectations of who needs to do what and when they need to do it. It definitely reduces your errors. And in the office, the systems I like to focus on are insurance, which really has to do with verification, authorizations, and referrals. I think the financial ROF is super important, educating the patients. The billing system is key, of course, because they're the ones that see the denials come through. Appeals, again, is key. And then making a system so that you can easily check on what's going on. And the key to checking on what's going on is touch points. We don't want to spend as much time checking the billing procedure as we do in the actual billing procedure. That means we're not just checking, that means we're redoing. So the insurance system, what does that really mean? Well, verification, we want to verify each benefit year. We want to remember those mid-year benefit periods. So my office was super, super busy the last couple of weeks because one of our major employers in our county is our public school system, and all of them reset on July 1st. So we don't re-verify their insurance in January, we re-verify in July because that's when their benefit year is. So making sure you have a system to recognize who those mid-year weird periods are. The EHR can help you. Most of them can set alerts so that you know when these dates pop up. If you're verifying on a website or within your EHR software, some of them will link to different websites like Availity. I always save a copy of the verification screen and store it in the patient file, because there was one time where we had done it and it said authorization was not needed. And when I went back to re-verify, the entire screen in the computer had changed. Because I had the PDF copy and it was date stamped, I was able to use that for the appeal, and we actually got paid because they had actually gone in after the fact and changed the benefits online because there had been an error with when it was originally loaded. So the more information you have, the more you'll be able to fight. If you do verifications by phone, I always get a reference number, I always get a date, I always get the representative's name. That way, when you have to do an appeal or you call back and ask a question and you get different information, I'll frequently say, really, because on January 1st, 2020, Susan G told me this, this, this. And then they get really, there's always quiet. I know I have them when there's quiet on the phone. So the more information you get, the better you're going to be. And I always like to use a set verification form. I know that Christy laughed that I'm the form guru, but yes, I use a set verification form so that you always get consistent information. You can't forget to ask one of the questions. And that way that if, no matter who in your office does the verification, that you're always getting the same information. So I like a nice systemized verification form. So managing authorizations, referrals, and maxes is part of the insurance system. Required after first visit with authorizations is very, very common. I hate when it says authorization may be required. You're probably all giggling because you've seen that before. What does may mean? It's either yes or no. Do they need it or not? But I see that all the time. It drives me crazy. But managing authorizations, referrals, and maxes, use your EHR software to the best that it does. They all have reports. They all have alerts. I use color-coded appointments. So in our office, if somebody is orange, they need an authorization, a referral, or they're hitting a max. There's something that needs to be looked into further. We use spreadsheets or lists, and you always want to make sure that your process has a follow-up at the end. So if you submit authorization to a website, you want to make sure you go in a day or two later and make sure it's come back if you haven't seen it come through. If you call a doctor's office and ask for a referral and you don't get it, you want to make sure you're following back up. If you fax authorizations, we do a lot of Medicaid in our area, and we have to fax authorizations, and they didn't get the fax. I'm like, I don't know how you didn't get it. I faxed it 3 times, and I have a fax authorization or a fax confirmation sheet. So we've won appeals on authorizations because I'll have proof that the faxes were sent and received, and they just didn't manage them on a timely basis. So again, the more information you have, the more power you're going to have. Financial ROF, patients do not ever understand their insurance coverage. They don't understand deductibles. They don't understand authorization. They don't understand any of this. They also feel that insurance should pay 100% of their care. They almost have this entitlement, why should I have to pay? I have insurance. Well, we know the truth. Insurance, that balance of who pays what is definitely been tipped the last several years, where more of it is falling on the patient. And this shouldn't be a surprise to them. This is your insurance company. You may be required to do something to get these bills paid. I always understand what an authorization is if they need it, because they have no idea what that is. I always to tell them what could happen, especially if it's like an ASH patient or any of those other really, really managed care carriers. This is how it works with your insurance, and you explain everything to them. And oftentimes what will happen is they'll call and they'll be super frustrated that they got a statement in the mail from their carrier, and they're saying, well, I got a bill from my insurance company for visits in your office. Well, we know that a health insurance company is never going to send a bill for visits in our office. And we remind them, well, remember I told you this was going to happen. They're like, oh, okay, I remember. So making sure that we explain as much as we can in the financial ROF, I think is very, very key in getting the patients on board with us. I always teach my clients, I've heard this for years, you've probably seen this before, you want to stay under the radar. We do this as a billing audit. Again, I have a form for this. If you're a Breakthrough Coaching member, it is 1111A. And what this does is it lets you calculate how many 98940s do you do? How many 98941s, 42s, 43s, and what's the percentage of where they are? So it is industry norms to do a 98940 about 35% of the time, and you go all the way through. But do you know where you fall? So I had a client, she told me that she could do 98942s 100% of the time. I'm like, well, I find that hard to believe, but let's see it. So I had her send me 5 patient files, and she hadn't documented it one time. So she was confident that she could verify it 100% of the time. And the files that we looked at, she hadn't documented it one time. Now I have another client. He does 98943s 99% of the time, but he is an athlete practice. He treats triathlons, swimmers, and dancers. And 99% of his patients come in with an extremity diagnosis: shoulders, arms, wrists, ankles, knees. So that number for him, while he's out of the norm, he can support it 100% of the time. Now, does that mean he's going to get audited? Possibly, depending upon what's going on with other stuff. But we want to stay within those norms as much as possible. Now, we did this in our office. We do it about every 6 months, and I do it over a 6-month period. Last year, with one of the 6 months, my husband was up in one of them. I think it was 4 twos. He was like in the 15, 18%. I said, why are you up? He said, that's what I got. He goes, those are the patients that came through the door. So I pulled 5 98942s, and I looked at them. He documented it every single time. When I did it the next 6 months, he was back down into the norms. So there are going to be times where you just get what you get, and sometimes there's no rhyme or reason to the diagnoses that come in. You may be outside of the norm. So just kind of check it. Of course, I documented everything in our compliance manual. If we ever got audited, I would be able to show that we're normally in norms, and here's the pattern. But this is a really good exercise to do within your office. Your billing system is key. So, yes, we need to get everything. It's almost like the front desk and the insurance system and the ROF system is your foundation, and then the billing system is like your building. So we want to make sure that we're looking for errors. So do you have ways to find where the errors are in your system or the rejection of claims? Are you posting EOBs timely? So nothing makes me crazier than an office that says, oh yeah, I pull them offline every 4 weeks. Well, a lot of these appeals have a time, like you have a time limit. It's not a timely filing, but it is a time limit to get that appeal in. And if you're only posting every 4 weeks, then you sometimes are going to miss that window if you're not on top of your game. I also have billers that will call me and say, like outside billers in a different, if they're not within the office, well, doc won't mail me the EOBs except for once a month. Okay, docs, if this is you, you need to get this going on a lot more smaller of a time frame. The quicker you get things done, the more likely you are to get these things paid. This is key. Every time your biller posts, whether they're out of the office or they're an employee in your office, I get a weekly issues list where it tells me that so-and-so denied because of this and so-and-so denied because of this. And I can look at it and see how many denials we're having and why. And it's a really, really nice way because I get a bird's eye view of what's happening. I don't have to look at every single EOB. I don't have to look at every single patient. I know we had 10 denials this week. 4 of them were for authorizations. Okay, what does that tell me? It tells me that the person who's in charge of authorizations is A, not doing their job, or B, my system is not working. So a lot of times what that will do is we'll streamline our system, or sometimes it means that I need a new person. Maybe I need to have a staffing change. The appeals process needs to be managed. You need to keep accurate records. You need to keep a list. It used to say that you would do a tickler file where you would schedule out, like if it's the 1st of this month, I want to check on this on the 1st of next month. So you could do it with a tickler file system, or I like using an Excel document and I put, when is my next touch date on this? And then I resort those Excel documents. So really that appeals process needs to have a follow-up with inside of it. And aging reports are key. This is your EHR software way of telling you what is outstanding. So aging reports are awesome. There's usually a couple different ways you can run aging. If I'm the biller, I want the most detailed aging report possible so that I know every single thing that's outstanding down to the CPT code. If I'm the manager or the owner of the practice, I don't need to know that Susan Smith's denied for bundling. What I need to know is that these 20 patients are in appeal, so I just need a bird's eye view. So I like aging reports to come across my desk as an Excel document that says the status and what is being done by them. And oftentimes what I will do, instead of reading them in alphabetical order, because that's just too much information to come into my brain, I will sort it by what is being done, because that tells me these 10 are in appeals, these 5 are looking to be refiled, and it tells me what's going on in big clumps. And it's really, really easy to manage that way. And then we want to make sure that your biller is statusing the claims often. What is happening? What is going on at that insurance company? So that is that. Error reports. Errors. So errors are going to happen. There's definitely things that are going to, you're going to hit a 9 instead of a 6 or vice versa. You might put in the first instead of the third. Like, things are going to happen within the office. It's just human nature to not do everything 100%, but we need ways to find them. So pre-submission error reports, I think, are crucial. You can usually find them in your billing profile somewhere. I can't tell you how many times I changed that her to EHR. I don't know if any of you have this problem, but every time I type it, it autocorrects back to her. And it drives me crazy. So, but if you have missing data, like let's say we didn't put a birth date in, or we were missing diagnosis codes, those claims are going to get stuck in your EHR software. They're not going to leave because they're incomplete, and your EHR software knows they're incomplete. So you need to make sure that you have a way to find them, and every EHR software has a way. Either it's a report, or in some of them there's a little spot down at the bottom that tells you that they are stuck in the software. But what you don't want to happen is a key employee leave. None of you know that this needs to be done. You bring in somebody who actually knows your software a little bit better than you guys do, and oh my goodness, you've got thousands of claims, hundreds or thousands of them in there that have never left the system. And I've seen offices where that has happened, and it's up to hundreds of thousands of dollars that have never been paid because they never left. And it's just because it's missing information, and it's just a simple data error. So you want to make sure you're running those reports. So if you're taking notes, write that down, that you want to do a pre-billing error report. You also want to see these reports from your clearinghouse. When my biller sends out billing, she gets a rejected report. It is empty 99% of the time. An empty report is just as valuable as a full report. That tells me that nothing's been rejected and she's doing her job. So if a claim was rejected by the clearinghouse, then that insurer does not have a record of that claim. And so you will get hit if you find it 6 or 8 months later. You're going to get hit with a timely filing because it never hit the system. Now, sometimes you can appeal with reports from the clearinghouse. Sometimes they'll go through, sometimes not. But you want to make sure that those clearinghouse reports and those errors get fixed. So usually what's happening with these is the information is sometimes missing, sometimes incomplete, but it's usually a data entry error, such as I put the birth date in, but it's incorrect. And because it didn't match exactly at the clearinghouse, they didn't have a place to put it. It didn't download into any carrier or any patient. So it didn't, since it didn't match up, it bounced right back again. So you want to make sure you fix that, because somebody did their job. They just typed in a wrong number is usually what happened. I always say appeal everything. I don't care what it is, you're going to appeal it. And don't forget to follow up. Remember, those insurance companies are counting on you not to follow up. Every dollar they don't pay a doctor is profit in the insurance company. And patients don't realize insurance is a business. The more claims they don't pay, the more profit they make. And it sounds terrible, but that's the way it's set up now. So second round billing is what I call it, or appealing denials. This is a key topic for effective claims management. You have to do it. So with appeals, what you want to do is, again, stay current on posting those EOB so that we can get those appealing time limits. We can get that everything submitted under those limits. Doctors, you want to keep current on all your patient notes so that appeals can be submitted immediately. So if we find out that I have to submit for bundling and I have to put doctor's notes in, I want that biller to be able to go in, print those doctor's notes, or do whatever they need to do and submit them immediately. I don't want to wait 2-3 weeks for those doctors to get current on their notes. So I get this question all the time, especially when we're in person. They raise their hand and they will call their docs out. What do I do if I can't submit appeals timely because my doc is behind on notes? And because they're so far behind on notes, they don't want to do, it's too big of a job for them. So what I always suggest what they do is put it on an Excel sheet of how many we're waiting on notes and what is the amount of money that's outstanding, and total it. When you show a doctor how much money is not being paid because you're waiting on them, they will make that a top priority. They will fix their system and they will get current on their notes. Now, this is a big project and usually you need some help in getting it done, but you guys got to get current. And a lot of times what we can do is just hire a scribe. If those doctors cannot stay current, they're so busy, we have a very fast-paced office, whatever reason, then we need to find a new solution or system. And that might mean having a scribe follow doc around and complete those notes. So that's what I always recommend in that instance. But we got to stay current. When sending a letter of appeal, you want to make sure you follow the directions. A lot of carriers have different directions. I'm seeing a lot of these where you can't appeal, that the patient has to do it. So this is where we push it back onto the patient. Don't feel bad if you need to call a patient and let them know they need to appeal. Remember, we told them in ROF that sometimes you have to take control of your bills. I had to do this with one of my daughters, that things were getting denied. And when I sent in the appeal, I got it to be pushed through. So sometimes it needs to be the patient's responsibility. Sometimes you want to copy the letters and appeals and send them to your state insurance commissioner. Sometimes there are cases of unfair practices. We've had to do this a number of times, and they usually, when we are 100% in the right, insurance commissioner can get these to come through for you. So I use those. A lot of times what I'll do is I put a CC at the bottom of the last appeal. This is going to go to the insurance commissioner. Most of them get paid once I threaten to do that. Couple of them not so much. I've had to send them in and I can get them paid that way. So those are the systems to prevent denials, but some denials are going to come through. I mean, that's just the nature of things. We're not going to be perfect in everything we do, but we have to ask why before the how comes. So why are things denying? And that helps us manage our system. So what I did is when I was managing denials, seemed to be getting too many of them. I took that list that I got from the billing person, that issues list, and I created a list. And these were the top 10 that were coming up. And then what I did is I created a system in place to prevent these things from happening. And then we just keep modifying the system as we grow bigger and bigger. Because sometimes a system that works when you're at a certain level is great, but then when you double the practice, that system doesn't quite work now that you're so big. And again, this is one of those things that you have to manage and look at. Just because my issues list has gotten super small doesn't mean it's going to stay that way. So remember I said empty reports are just as valuable as full reports. If you're getting EOBs posted and you have 0 issues, please send that in a report to your managers or your doctors. That is super good information to have. And I watch those reports. I watch to see how long they are. When those reports get longer and longer, or I get more and more patient statements, that's usually a sign that either A, the system's broken, or B, the staff member is not working out in that position. And oftentimes I'll do a staffing change. We had that happen with COVID. One of my key staff members couldn't work for various reasons, and my issues list it didn't just cut in half, because I expected that to happen because our numbers cut in half, but it cut in like down 3/4. So I knew some of it was numbers. I knew some of that was because that employee was not exactly where she needed to be. So we changed some systems up. We had a conversation with her and we're back on track now. So here's our top reasons for denials. Number 1, you didn't get authorization or a referral. They're waiting on an accident or injury form. They deem it not medically necessary. They decide that it's bundled. It's really not a covered benefit for their plan. Your provider is deemed not in network when you know full well they are. Inaccurate patient responsibility. This one drives me crazy. They have a maxed benefit or it's not a benefit. Constrictive rules, we'll go over some of those, and loss of coverage. So number 1, referrals and authorizations. So not very many people have referrals nowadays, but there are still a few authorizations. It kind of depends upon your plans and which ones you agree to be a part of. Again, the authorizations is a game. If you fail to obtain these authorizations or referrals, you have to prevent this because they cannot be appealed later. If you know they need authorization and you don't get it, you will not get paid. So on insurance verification, you want to keep a copy of it with the reference number. You need to know what your plans are so that if you're doing verification by phone and they tell you that authorization is not required and they give you misinformation, you can call them on it. When I know authorization is needed, so I need to know my plan, I'll just submit it anyway, even if on insurance verification they tell me it's not needed. It only takes a couple minutes to submit these authorizations, and even if you get a denial back because it's not needed, that's better to have than to have need it. It's better to have it and not need it than need it and not have it. And I keep that documentation. We've had it where we were told they needed authorization. We submitted and it was denied for authorization because it wasn't needed. Then the claim denied. So I put everything in an appeal and sent it back, and we actually got it paid because I had submitted for it and it came back not needed. I always hate authorization may be required. What does the maybe mean? It's either yes or no, give me an answer, and they never do. So we submit one just in case because, like I said, it is easier. Here is my authorization system. So number one at the top of the circle, you need to identify who needs off and when. So you do this off of your insurance verification and knowing what plans need things to happen. You want to have an alert system or 3. In my office, we have 3 alert systems for authorizations, referrals, and maxes. We use the EHR dashboard or reports. We have an authorization report that we run on Mondays. It tells me, I've set it up so that, and I set the parameters in it. It tells me who needs authorization within the next 5 days or 3 visits. So that tells me when I run it on Monday, everybody who needs authorization between now and Friday. Oftentimes we'll color code the appointment. So if I know they need authorization after the 5th visit and I have pre-scheduled my appointments out, I'll change that 5th visit color in my EHR to orange. That lets everybody who sees that patient in the appointment book know that today is the 5th visit, something important needs to happen. Our system also allows us to do patient alerts, and so we'll set an alert as well. What this does is it gives me 3 deep. So if the person who is running authorization gets busy, is sick, or off their game that day, there's somebody behind them that can remind them that, hey, authorization is due. What she does with that report is she makes a who is due today list. We have an Excel chart. She fills it out every Monday, and then she highlights a to-do list and gives it to the appropriate person. Sometimes the authorization person will submit the authorization. Sometimes the doctors have to put some medical information in. Sometimes our doctors do it. So we give them a very concise list. They know exactly what needs to happen. You can use Excel charts. You could use to-do lists. You can make it handwritten. You can do digital organization. You can use something like Asana, whatever you want to do, but you need to have it be organized. And you have to actually follow through. So I've had a couple docs that I coach that they say that they can't stand the authorization process and they just don't feel like submitting it. And I tell them that's fine. If you're going to refuse to submit the authorizations, then you need to get out of network with those insurance companies because there's no point in treating the patients for free. So if you need to do authorizations and you've agreed to this insurance plan as one of their providers, submit the authorizations. Just do it. Make sure you follow up. Sometimes you have to go back in and see where the authorization is in queue. Sometimes you have to do a doctor review. Sometimes if you faxed it, they will have lost it. Sometimes you have to follow up with those doctor's offices if it's for a referral. They don't always see the need to send referrals timely. They are emergency, they don't really care about. Especially during COVID, I'm finding that primary care doctors are being especially slow. So you want to make sure that you guys are leaving some more days in your scheduling if patients need referrals. You want to then, once you get that authorization back, enter the information into the EHR. So you're going to put the auth number in, the number of visits, and the date range, because then what's going to happen is your EHR will alert you again and you'll start the whole system over again. So number 2 is waiting on an accident and injury form. This one drives me bananas. So I always inform the patients during that financial ROF, it is common that you'll get an accident or injury form from the insurance company. This wording may be confusing and it may lead you to believe that you only need to fill this out if you were in an auto accident. Please fill it out regardless and put a big no on them and send it back to the insurance company. Please don't forget to do this because your insurance company will not pay your claims until they've gotten this paper back. I always let them know, please send a copy to the insurance company as directed. Please bring us a copy to the office and keep a copy for yourself. Many insurance companies will claim they did not receive it. I've had them even claim 2 and 3 times that they have not received it. So if they bring a copy into the office, you can make sure that you're getting it done and you're getting it submitted. So patient education is key on that one. Denial number 3 is not medically necessary. Our definition of medically necessary and the insurance companies definition of medically necessary, we all know that it is not the same thing. So we want to make sure that we're keeping good, clear, compliant documentation. You need to know your insurance carrier's rules, both the written rules and the unspoken rules. So what this means is a lot of times we know that they have a max of medically necessary. What does that mean for this insurance company? Does that mean it's a hard max? Like with my office, Aetna makes it a hard max at 25. No matter what you do after 25, they're not going to approve them. Some of them it's per diagnosis. So if you have one diagnosis, it's 12 visits. If you have another diagnosis, it's 30 visits. Some of them it's by how you're recording their progress. So if you're not changing the treatment plan and they ask for medical notes and you're not showing that they're progressing, then they're going to deny it for not medically necessary because they're not getting better. You haven't documented it. We had one denied once because the patient was an MMA fighter and kept getting themselves hurt. And so their insurance company refused to cover them anymore. Use your EHR to count down these visits. So if I know, like with Aetna, that it's a 25 visit max, I put that in as a 25 visit max, even though it says unlimited. I do the same thing with all of my carriers. And you want to explain this to patients. The way your insurance company works is, and you tell them how it's going to work. And if you tell them this in the beginning, you can enroll them in ChiroHealthUSA, put it as part of their payment plan, and it rolls right in. So we can switch them over and convert them to those self-pay fee schedules you've set up. And so then you won't get those denials. Denial number 4 is bundling. This is super annoying as well. So they do this a lot with exams. So you want to make sure you're using the 25 modifier the way you need to. You need to make sure you're billing exams at the correct frequency. So if you're billing exams every 4 to 5 visits, that's too frequent unless you're having a diagnosis change. So let's say somebody came in on a new patient exam on Friday, and then on Monday they fell down the stairs and you did another exam. Well, you have a new injury. That's likely to be paid. But if you're just randomly doing exams because you want to at a 6 visit frequency, those are not going to get paid very well. You want to make sure that you update the diagnosis after the exam. This shows that you've updated and updating the treatment plans. And you want to change the goals. This shows that an exam was really done, was really warranted, and that you're making changes in what's going on. If it still gets denied, you want to appeal it. Use your state and national associations if you need to. Again, you can appeal to the state insurance commissioner. Sometimes they just do stupid stuff. Like I know right now, Virginia is an issue that they're bundling exams, and the reason is it's part of the surgery. Well, we all know that a chiropractic adjustment is not surgery. I have one office, they've appealed it 3 times, and it's still being upheld. So they had to go to the state insurance commissioner. The state association is helping with this, and it's a big problem across the whole state. So when you know that it's definitely an error, don't just give up. Now, it's annoying that you have to keep fighting, but go ahead and just keep fighting because likely there's an issue in their computer that needs to be fixed. I've actually had the insurance company have to change their billing software because they've got it set wrong for something similar to denying for bundling for surgery exams. Therapies, the 97140 and the 97124, sometimes will deny and they'll be bundled. So you want to make sure you're using that 59 modifier. You want to make sure that you document thoroughly and you show those separate regions and you link those diagnosis codes. Denial, this is not a covered benefit. There are some insurance companies that do not cover certain things. Sometimes it's range of motion. Sometimes it's an extremity adjustment. It just depends upon the carrier and what they've decided to do. So you want to make sure you're verifying insurance coverage. We've talked about this before. You want to watch for carrier changes. Many times the patient doesn't think anything has changed because their copay and their deductible didn't change, but sometimes there's little bits of information that they have no idea about. So is there a plan or policy change? And did they inform, or maybe they made a global change, like they're no longer going to cover X, Y, and Z. They will likely do this via fax, email, or a message on your online portal. If it's a message on your online portal, once they've posted it, they've told you. So it's your responsibility to check those portals and see if they have any carrier changes. They're not going to say, well, I didn't know that there was a change to billing. They don't care, the insurance companies. It's your responsibility to find these changes and know them. I like to keep a master at a glance insurance list. So out of state and self-funded plans, we know that those don't follow our usual norms. Sometimes they will have different coverages. Sometimes they'll have very limited what's going on. and it looks like a Blue Cross plan, but when you call and verify, it says self-funded. So be very, very careful when you're watching that. I've also seen some plans that, like with us, M&T Bank, their plan is super, super restrictive and say they have chiropractic care, but they don't pay chiropractors, which I know sounds crazy, but you've probably seen some of those type exclusions. So when you call and verify the benefits, they'll tell you all the chiropractic benefits, and we are indeed in network with Blue Cross, but because it's an M&T plan and it's self-funded, they have an exclusion that I know about. So I have it on that master at a glance list because you don't find it out on insurance verification unless you know what question to ask. So asking about exclusions is also a very good thing to do. Denial number 6, your provider's not in network. You want to watch your credentialing updates. These things are going to come across in the mail, again, email, fax, your online portal. If you miss a re-credentialing update every 3 years, they're going to bump you out of the network and your claim. Now, it's an easy fix. Put back into network and you resend them in, but you need to be on top of it. So watch for re-credentialing every 3 years. Your CAQH needs to stay updated. Sometimes this re-credentialing, if you keep that CAQH updated, happens without even noticing. Oftentimes you have to have a current malpractice declarations page. So have it be really, really one of those things in your office that every provider, each time you get one of these new declaration pages, that you load it up to CAQH so that it's seamless. Beware that adding a new provider may result in credentialing current providers. We had this happen where we added a new provider and something happened in the system where it clicked the entire office as out of network. It took us about 8 months to get it fixed. So you want to beware because sometimes the error is in the computer system, the insurance company. What I do is batch the appeals and submit it as one large project. But I had to go 2 or 3 supervisors up to make it happen. So push, 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 and fight. Remember, I said knowledge is key. Denial number 7 is the incorrect patient responsibility. This one frequently occurs when you have a deductible and it's incorrectly assigned to the patient. Usually it'll happen when they say that they have a deductible apply within this. Sometimes they give you misinformation. So verify the insurance and keep a copy. Re-verify after the denial. I always re-verify and act real dumb, like I'm verifying it for the first time. Then when they give me the same information again, I ask them, then why did this process as deductible? They'll oftentimes submit it for reprocessing for you, and then I oftentimes will inform the patient because nothing makes a patient madder than when we think a deductible doesn't apply because that's what the insurance company said, and then it comes through as deductible. So I often immediately tell the patient and have them call as well. What that does is it gets the answer to go straight to the patient, not via through me. So now the patient's company, not at us. So if it does happen that yes, it is the deductible, the insurance company told the patient, and the patient's more likely to pay. So sometimes the denial gets paid by the insurance company. Sometimes it does get pushed to the patient, but I would much rather the insurance company tell the patient that than me. Denial number 8 is we're maxed or it's not a benefit. Again, look at these insurance verifications. Look for exclusions. Like if you do foot orthotics, some companies will pay for them, but they have exclusions that you can only do it for diabetic patients. Sometimes if you do acupuncture in the office, there'll be an exclusion for diagnoses or certain reasons why you're doing it that don't have anything to do with what you're doing. Like there's a number of plans that will cover acupuncture if it is for surgery, which is not what we're doing in our office. So if you verify the benefit, it is there, but when you ask for an exclusion, they take it away. Are there only specific diagnoses that are covered? Track these number of visits when they're capped so you can let a patient know when they're going to max. Like we said before, roll it into a treatment plan, into a payment plan, and convert them to Chiro. When these maximums are met and the services are not covered, you can still get paid from the patient. Denial number, these plans have constrictive rules: personal injury, Medicare, Medicaid, federal plans, workman's comp. A lot of them have different rules. You need to know what's going on, specifically in your state. You need to know what's going on. So denials for personal injury, you need to follow your state regulations and submit within the certain number of days. Florida has a very, very strict days policy. I treat my clients that are in Florida, we treat those filings as needing authorizations. We track them the exact same way. So we never want to miss some because we missed the date range. ROF and financial consult, I want to follow up with them on their medical claim. We make sure we explain that there were two types of claims that you're submitting, one on your vehicle and one for medical. Oftentimes they're very confused in the process. Set up a claim, yes you did, but that's for your car. You need to set a medical claim as well. What happens after they exhaust benefits? I want to let them know, you have this much PIP on your policy. Oftentimes a treatment plan in our office comes in at this amount. Once it exhausts, you're going to need a lawyer or maybe health insurance supplement. Some of those health insurances, though, will have an exclusion for auto accidents. We have a number of policies in our office where they will not pay if it's part of an auto accident. So you want to know that ahead of time. Also in our office, we are finding that there's a certain company that has a that goes with them. It begins with a G, ends in an O. They are notorious for waiving PIP, and the patient has no idea they waived PIP. So making sure that you call that insurance carrier, making sure that that PIP is something that they can access and they have not waived it. Nothing makes a patient more frustrated than getting halfway through a treatment plan, having all the bills denied because they waived PIP and they had no idea they did that. And oftentimes it's because they bought the insurance online and it says, save money by clicking here, and they have no idea that they've clicked to waive that coverage. Workers' compensation, these can be some nice claims to have, or they can be a super huge headache. So federal work comp is very restrictive. Sometimes you need to have certain credentialing. We found that it works like Medicare and it's very restrictive. We can do it and that is it. So steer away from federal work comp unless you have gotten put in as a federal workers' comp PT facility. Make sure you're obtaining authorization. We've had a number of patients that are doctor hopping, and I'll call for authorization, and their caseworker is absolute that this person, they're either not complying or they're streaming it along. There's a lot of fraud in workman's compensation, so you want to protect yourself from fraud on the patient side. You want to make sure during the financial consult that you're talking about, we've verified the status of this claim. If it's still decided if an accident, I am very weary of taking them if they don't have a lawyer. If it isn't a firm accident, yes, here's the case and here's the claim number. If it's still in review, it's kind of iffy. I like to have things more laid out. Lawyers are wonderful. Knowing their health insurance is key as well, because if the case does fall through and they've got Blue Cross and no authorization was needed, you can quickly just bill their insurance and their Blue Cross carrier. Denials for Medicare, this one drives me insane, monthly maxes. So Medicare had a max where you can have 12 chiropractic adjustments per calendar month. So usually you're thinking, well, four weeks, 3 times a week, that's not a big deal. It is a big deal. If they come in on the 1st of the month, and the 1st is on a Thursday, and it's a 31-day month, and you're seeing them 3 times a week, likely they're going to come in on the 31st or the 30th, and it's actually going to be your 13th visit. That visit will be denied. Now, let me say that again. If you've Thursdays in a month, and this happens if they come in on the 1st and it ends on the 31st. It doesn't happen often, but when it does, that 13th visit is going to get denied. I've seen it happen, and it's annoying. So kind of watch that when the 1st and the 31st are both on the same day in a 5 Thursday. And it could be any day of the week, but that's just the example I gave. Most of you probably already know this, but chiropractic services are subject to diagnosis and procedure code restrictions. So if you're a group A diagnosis, you get 12. If you're a group B diagnosis, you get 12. If you're a group C, you get 24. And if you're a group D, you get 30. You can find those listings on your local LCD sites if you search for them. But those things are in effect. So TMJ is not, as if I recall correctly, is not a group D diagnosis. You will likely not get 30 visits for those type of TMJ is not really a subluxation unless you're pushing the diagnosis up to the neck. So you want to make sure that you're diagnosing properly, and that you never want to get a diagnosis does not support. That's annoying to get those. If you've got associates, please make sure that they have good training on diagnosis codes and you're all on the same page. Make sure you're reading the insurance cards when they come across the front desk. I know we get super busy and we just get in the process of scanning the card and sending it back and handing it back, scan the card and hand it back. My staff did this the other day. Well, I brought it back up after the claim got denied. It clearly states on the card that the patient has Part A, hospital only. I look at the staff member. Why did you do this? She goes, I didn't even read it. So we need to make sure that we take a second to read the card. So now this patient's come in 6 times. None of them are going to get paid for because she didn't read the card. I can't bill the patient, and the patient has no other insurance. Denial number 10, loss of coverage. You want to make sure you're checking eligibility again, at least each year, or upon reactivation. So if they've left your period of time, it doesn't hurt to just re-verify that they are active, especially during COVID. People are getting terminated or laid off or furloughed. Some of their insurances are staying put, some of them not so much. So right now it's super, super key to check eligibility each time they come in. Union plans, so if you have a big union, we have electrical unions where we are, they earn their insurance each month. So sometimes if they didn't work enough hours and they didn't pay their premium themselves, they'll have a period of time where they're not covered and they have to call HR, get it reinstated, and then rebill. So check on those as well. Plans, like I said, we do a lot of these. Income must be verified. I think it's once a year or once every 6 months. If they get that notice and coverage is going to be terminated if they don't submit those documentations. So a lot of these EHR softwares will have an eligibility button. It takes a second to hit it. Is it annoying? Yes. Does it make sure that you know what's happening? Yes. I do recommend we do that. So our management system, this maintain a checks and balances system to ensure all your systems are working properly. So I have a way to know what I do is I give my biller, everything goes into a folder on Friday. So when I check next Friday, she's likely finished the folder before, unless she's been on vacation. So I know that we have a week on date on our posting. I don't have a posting problem because she knows I'm going in there and checking. I will randomly pull 1 to 2 EOBs a week and just see if she posted them correctly. She knows I do this. She checks her own work. We also have a way to check and make sure that that if I have, let's say it's $5,000 of checks that she posted, that when I run a report in the EHR, she's posted $5,000. So that's another way to check and make sure that everything has been posted. Are appeals being submitted and followed up on? Again, when I pull those, I look at those reports that they do, they tell me what's going on. Are there any data errors? I see the error reports come across my desk with check marks on them. I don't actually read them, but I know they're happening because I see them come across my desk. Are there EOBs with no payments or payments with no EOBs? This is key, especially on the EFT side. I like to hold monthly department, and I proactively will review them aging reports. Again, I like to see them on Excel documents. What this does is it helps you to make sure that you are driving your train and it's staying on the tracks. If you know what's going on a touch basis, then your biller knows what's happening. Your biller knows that you're checking on them, they're dotting their I's, they're crossing their T's. When an error does happen, a couple weeks ago, we were off on the folder. I asked my biller, hey, what's up? She goes, oh, I missed a check. She went back in and she fixed it right up. Errors are going to happen, but the quicker we find them, the better it will be. Audits are key. I know this isn't part of the appeal or denial process, but it is an OIG requirement. And because I'm a compliance officer, we do like to talk about OIG. So we recommend you do billing audits. If you're a Breakthrough Coaching member, again, I have a form for that, 1111B. But it basically takes you through what is paid. Was it posted correctly? Did we do the patient responsibility correctly? Did the patient pay? Why was it denied? Was it appealed and resubmitted? Could the denial be avoided? You want to make sure you're doing this at least on a yearly basis. I like my offices to do it on a quarterly. That way the project isn't too big. Some of my offices, instead of doing it as a big project, they're just auditing 5 per week just to make it part of somebody's job description to do it. It keeps you right on task with what you're doing. So I really recommend you do some audits. They're simple to do. All you need to be able to do is read an EOB and read your office software. So if you need some help, if you're thinking, oh my goodness, what is she talking about? What are these reports that I need to run? I've created a form because of course I love forms, but basically it's through daily, weekly, monthly, quarterly, yearly reports that you could run in the office. It tells you the frequency that you can run them. It gives you some ideas of who could run them, who should look at them, why you want to run them. And we will give that to you for free if you text CHUSA 123 to 33444. You can get this form and it will go through everything. how to run this report in your EHR, contact your vendor. They'll likely give you instructions on how to do it. A lot of these can be Excel documents. I love Excel because you can manipulate them, you can sort them, you can make nice, concise lists, you can add columns for in case you have to get billing to respond and you bring it back, or you have to leave a note for your doc. It's a really, really nice way if you can have them go to Excel documents. So it's a team approach. So I thought this was kind of funny. Of course, I don't look busy. I did it right the first time. It is always easier to do it right the first time. So managing insurance denials can eat out hours of productive time. And it's frustrating. It makes you angry. Nobody likes to talk to an insurance company. Getting them on the phone, talking to a wall. Sometimes you get in an endless loop. It's not fun for anybody. So when all team members do their part, the entire practice can fun with, and that is patient care. I would much rather talk to a patient than I would with an insurance claims person to get something paid. So the better that the whole team does, the easier it's going to be. So the key to denials is prevention. And that is all.
Thank you so much, Wendy.
I know I talk fast. I'm from the East Coast.
Girl, I live in the South, but I was raised by Yankee parents, so I talk faster than most Southern people.
Oh my goodness.
I always tell people before I speak in person, I'm like, if y'all can't understand me between the accent and the speed, just go like this. I know what that means.
We're right at an hour too. How good is that?
We're kind of amazing like that. So I have 2 questions for you. And the first is, when I get a denied claim, they tell me to look at the denial code, but when I go there, the denial code is very confusing.
Oh my goodness. I would imagine what you have to do is go into your carrier's websites. There's probably some sort of provider, and they don't give this stuff to you. You have to go hunt it down. It's annoying as anything. Find the provider instruction book where it tells you there's likely a list of denial codes in there. Or you just keep calling the claims department. I just keep asking for supervisors until I get somebody that is helpful. And sometimes I'm like, I just don't understand. Please just help me. Can you just help? And sometimes they will pity you and they'll give you the information. And if you don't get it right, like if you can't get someone to help you the first time, hang up and try it again. But likely if you can get a supervisor, and nobody likes it. Like if I call the 3rd time and I say, I don't want you, I want a supervisor. They get in trouble for all the calls, and they will likely help you because I refuse. Nope, want a supervisor, and then they will likely give me an answer.
I love that. And
if you don't get any answers, send a message to your state association. That's what they're there for. And if you're seeing it in your state, somebody else is likely seeing it too.
Right. Oh, I totally agree. We have hung up and called back because you will get a nicer person sometimes the 2nd or 3rd time around.
Well, and right now, so I love it when you hear the dog barking or the kids. Hear the soap operas in the background. I'm like, oh, are you watching soap operas right now? They will answer any question if I catch them off task.
So my next one is, what do you do about appeals for out-of-network claims? Do you appeal asking for a higher percentage reimbursement or ask for a specific amount when they pay way too low?
I don't really have an answer for that one. I always tell everyone, I'm not really out of network very often, and network, you didn't agree to anything, but like with everything else with insurance companies, when you send things to an insurance company, you're at their mercy to play their game. And so I would say let the patient appeal it, or don't bill things out of network anymore, especially for that carrier. Have the patient pay and let them submit it.
I agree. Let them.
Yeah.
You choose.
I mean, you're out of network. They don't care. And here's what I've decided with insurance companies, because my staff has always asked me this. Why do they lie? Why do they give us misinformation? We are not the client. They don't care what we say. I told one once, well, I will just come out of network. And they said, okay, we don't care. Like literally the person told me this. The less they have to pay me, the better. Now the patient is the client. So if you can push things, especially these out-of-network things, to the patient and have the patient complain, they'll likely do things for the patient they won't do for you. They don't care about you. It's in their best interest if you go out-of-network, because then they don't have to pay you.
True story.
Or the patient will go someplace else because they don't want to go out-of-network.
True. And I was going to say you have a lot more negotiating power when you are in network and you can justify you can, people don't realize this very often, but you can ask for them to reevaluate what they're paying you and negotiate your fees with the insurance company. So, but if you're out of network, you don't have a contract with them, so they don't really care.
Yeah, they don't care at all.
They don't. Okay, so that was all the questions we had. And somebody said, is this recorded? Because they wanted to watch it again. And of course it is. And in an hour, y'all are all going to get an email that says it was recorded. Watch me again. And if you just happen to be watching the recording now and you have a question and you're like, man, I wish I'd have been on there because I had the perfect question for Wendy, you can put it in the chat box and it's going to email it to me. And then I'm going to email it to Wendy and we'll get you an answer and we'll email you back. So it's a win-win-win-win.
And because we have a system of follow-up, you will definitely get an email back.
Oh yeah, she's like amazing. She does. She has systems for everything. No joke. Like my little organized heart loves the Wendy and her processes. Love them. And it is no joke. Like sometimes I'm just random. I'm just like, so Wendy, do we have a form for that? Yes, we have a form for that. We have a form for everything.
Well, and I didn't tell you, so when you get that list, you'll see down the side, because it is a breakthrough coaching form. It tells our members what form tells you to run that report. So you don't even have to remember to run the report. If you're using our form, it tells you to do it. Run this report today.
I love it. I love it. Oh, we have one more thing real quick. Can you have the patient contact ASH because their insurance provider claims they don't know they exist? No one can ever get a straight answer. Patients don't even know this company exists.
Nope. Okay, so ASH is the insurance company made by the, I didn't say that out loud in case anybody works, but ASH is terrible. So I actually got a hold of a patient once, and the patient was livid. Like, this was the maddest patient I'd ever seen. Because when I call, talk to ASH, but when they call, they get whatever company that they are with. And so what happens, like, their EOB, they brought it to me and it said that they paid X amount of money. But then I showed them my EOB that shows the cut that ASH took, and that patient was madder than mad. The only way to get their game. So you either play their game by their 6 stupid twisted rules, or you get out of network with them. And I do, but they don't really understand it. So what I tell them is it's a third-party management system. Whatever their insurance company, mine doesn't feel like managing the claims to us, so they farm it out to an independent contractor, ASH, and then ASH pays us. And when I explain it like that, they kind of understand. I said, but you're going to call your company. They're not going to tell you about ASH, and they're not going to tell you that they exist. I'm like, oh, okay, because they farmed it out. So you just kind of tell the patient what's going on. I've had some providers like, I can't anymore. I said, that's fine. Then go out of network. You might lose some of your patients, but if the game is making you crazy, or it's too much hours to get the claims paid because ASH pays a little amount of money, then you have to see if it's worth the effort. In my area, the county next door has Cigna, but they don't need authorization. So for us, it's worth the patients that do, because there's a ton of patients that don't, and they all refer a lot because we're the only doctor that takes it. So you kind of have to look and see. It's not always a yes, you should stay, and it's not always a yes, you should get out. But no, there's no way for that patient to talk to ASH. That won't happen.
It won't. And I was going to say, so this is what I tell doctors as soon as they say ASH, I'm just like, okay, listen, I understand your pain. But yeah, they're kind of a hassle to deal with for like 5 visits, right? Like 5 visits, 6 visits, maybe. But at that point, they just become a self-pay patient. But you need to look at your referral source. How many referrals are you getting? How many of your patients? Because we don't have an ASH, but we have another insurance company that is a Royal PIA. But they are the #1 referral source to our practice. So we tolerate them for 5 visits. Why? Because after that.
Well, and if you play the game properly, so with us, I get the first 5 visits with no authorization. Then I can likely get 3 authorizations in. So I can get 5, an additional 4, an additional 4, and an additional 2. So likely in our office, I can get up to like 12 or 15 sometimes, depending on how my documentation is. That's worth it, because then that's half of a treatment plan, and then the rest of it's self-pay.
I love it. So I just want to remind y'all that we have a webinar next week with Dr. Sherry McAllister, and she's really going to get into the heart and soul of what chiropractic is. It's not just a responsibility to adjust and heal patients, their body, but especially in the wake of a pandemic and all that we're going through, it's also about their mind, body, and spirit. And it's about making sure they are being healthy, they're exercising, they have adequate nutrition, and how we have those conversations and educate them. So if you didn't register for that, please make sure you do. You can go to ChiroHealthUSA.com /webinars. And then we're going to talk about accounts receivable the next week with my good friend Nathan Unruh, because it's not all about the money, but the bottom line is we can't have the miracles happening in our communities day in and day out if we don't have the money to keep the lights on, to pay our amazing team that is keeping everything running. Because bottom line is, the chiropractic practice is only as good as the team that runs it, and that costs money. So we got to keep the money coming in by avoiding insurance denials and making sure we're collecting the money in the office. So make sure you register for those webinars. And if you, again, have any additional questions, just send those to me by email or put them in the comment section. We'll get those over to Wendy and we'll get a response to you, because she is so timely. I'm going to be a Wendy when I grow up. Anyway, Wendy, thank you so much for doing this today.
Thank you for having me.
I miss you so much. So everybody, it's been good to see you today, and I will see y'all next week, same time, same place. Y'all have an amazing rest of your week. Get some rest this weekend because you deserve it. Bye, everybody. Oh, where's my mouse?